Let's get started. Everyone, do you have my voice? Thanks. Hi, everyone. Welcome to the first session of Rheumatology CPC series held by Rheumatology Division of Shariati Hospital, Tehran University of Medical Sciences. I'm Dr. Faize Bijani, Assistant Professor of Medicine, Shariati Hospital, Tehran University, and Head of Educational Developmental Office of Shariati Hospital. I'm gonna present the case which was published by New England Journal of Medicine for you. But before that, let me introduce my colleagues and team cooperating to hold this event. Dr. Tahir Faizi, Professor of Rheumatology, Head of Rheumatology Division, Head of Connective Tissue Disease Unit in Rheumatology Research Center. Dr. Faizi will manage the case discussion. Dr. Elahe Baharvan. Dr. Baharvan moderates the event, collects your questions, and will respond. If you want to keep in touch for the next sessions. Dr. Baharvan.
Thank you, dear Faize. Do you have my voice?
Yeah.
Thank you. I want to say hi to all ladies and gentlemen, and on my behalf, I want to welcome you all to our first session of CPC, and thank you for your participation. Please feel free to ask your questions in the chat section. It is better if you send your scientific questions to me, Elahe Baharvan, as the moderator. If you wish to receive a certificate for each session, you need to register via Upraise to Raise website, and I will share the link in the chat forum. Please make sure that the name that appears in your Zoom matches the name that you entered when registering. And at the end of the session, I will share the article for further reading on the case discussed today in the chat. Also, we will be very grateful if you could fill the feedback form that we share in the chat forum at the end of the session. Thank you very much.
You're welcome. Thanks, Dr. Baharvan. We are super honored to host Dr. Arezu Khosrowshahi, Associate Professor of Rheumatology. Dr. Khosrowshahi, thanks so much to accept our invitation. Dr. Khosrowshahi is Associate Professor of Rheumatology at Emory University, USA. We're so much pleased to have you with us.
The pleasure is mine. Thank you so much for inviting me, and I'm so proud of you guys to put this program together. I had presented CPCs at Shariati Hospital when I was a medical student there, and it's really an honor for me to be back.
Thank you so much. We also have Dr. Hakim Sadeqian. It's a great honor for your joining. It's a great honor to have you with us. Dr. Sadeqian is Associate Professor of Cardiology, Echocardiography at Shariati Hospital, Tehran University of Medical Science. Dr. Sadeqian, we're so much pleased to have you as well.
Hello, everybody, and thank you for inviting me.
You're welcome. We're also plan to host Dr. Samir Belagej, Associate Professor of Neurology at Emory University School of Medicine, USA, but I think he has a delay, and we would be pleased to host him as well in a few minutes. But I think we're gonna start our presentation now. As I said, the case I'm gonna present for you is a medical case presented in New England Journal of Medicine. A 41-year-old woman presented with facial droop and transient dysarthria. She presented to the emergency department with heavy vaginal bleeding, crampy abdominal pain, fatigue, dyspnea, and lightheadedness 3 weeks ago. At presentation, her heart rate was 91 beats per minute, blood pressure was 130 per 79 millimeters mercury, and other examinations were normal. Her lab data at presentation was a hemoglobin level of 8.2 gram per deciliter with a MCV of 71.3 with a normal platelet count and a urine HCG, which was not detectable. The patient was treated with a bolus of normal saline and a depot of medroxyprogesterone acetate for 5 days. However, 11 days later, heavy vaginal bleeding recurred and an additional 3-day course of medroxyprogesterone acetate was administered again. 5 days later, after the patient finished the second course of treatment, acutely facial droop and on the right side of the face and a slurred speech occurred, and the patient was immediately transferred to emergency department within 1 hour after the onset of symptoms. At presentation, her heart rate was 91 beats per minute with an increased blood pressure of 173 per 83 millimeters mercury. She has facial droop on the right side and unintelligible speech. Immediately, a brain CT scan was performed for the patient showing no acute intracranial abnormality and the evidences of small chronic infarcts in right thalamus and right cerebellar hemisphere. A CT angiogram of the head and neck did not show high-grade stenosis nor large rectal occlusion. Unfortunately, we don't have access to the images of the CT angiogram and the further CT scan images. At that presentation, lab data was performed for the patient and it included normal electrolytes, normal albumin levels, LDL and A1C was normal, white BC was normal, and a hemoglobin level was 6.7 with MCV of 64. Liver and kidney function tests were normal, and again, undetectable urine HCG was recorded. In urine analysis, 3+ blood was reported with no protein and no CAS. As treatment, aspirin and atorvastatin was administered for the patient with an emergent neurologic consult, which was obtained. 2 units of Paxil were transfused for the patient, and also an EKG was done, which was normal. Fortunately, within 45 minutes of admission, the facial asymmetry and dysarthria resolved. Here, you can observe the lab data of the patient in the initial presentation of the patient to the second hospital. As you can monitor here, the patient has an increased PTT and presentation, a decreased level of hemoglobin, and also an iron deficiency anemia. ESR or erythrocyte sedimentation rate was also increased. Subsequently, the next day, a brain MRI angiography was performed for the patient, which can you see here, the images of the brain MRI with contrast, and also the brain angiogram. As you can see here in the cerebellum and here in the thalamus, there are the evidences of old lacunar infarcts. The report was reported as old lacunar infarcts in the right thalamus and right cerebellar hemisphere. No evidence of acute infarction, intracranial hemorrhage, and nor cerebrovascular occlusion was reported. Subsequently, an echocardiogram was performed for the patient, which we can have access to the video. We asked Dr. Sadeqian to report the echocardiography for us. as soon as I share the page.
Dr. Bijani,
Yeah, I hear you.
we have Dr. Bella Gage here with us.
Oh, Dr. Balagage, we're so much welcome to have you. It's a great pleasure to have you with us, and we ask you to have a brief greeting with the audience. Do you hear my voice, Dr. Balagage?
I hear you now. Can you hear me?
Yeah.
Okay. I'm sorry. I had myself on mute. Sorry about that. Good morning. It is an honor and pleasure to be with all of you this morning. I'm looking forward to going through this case with all of you and learning a little bit more myself. So, morning or good afternoon, I should say.
Thank you so much.
Yeah.
Thank you so much. We're so much honored to have you with us. I hope you have heard what we have presented about the patient. So
Yes,
here we have,
yeah.
good. Here we have the images of the brain MRI of the patient. Could you please help us reporting the patient, reporting the images of the brain MRI and also the brain angiography?
Yeah. So there is not much to say because there's a lot of normalcy to the brain. The one thing I will point out for and that's not surprising because this patient was diagnosed with a TIA. By definition, a TIA does not have any acute injury to the brain. So when we diagnose a TIA, we expect to see essentially a normal brain or a brain that does not show any acute pathology or acute injury. And that is basically what we are looking at here. The first MRI is what we call a DWI or diffusion restriction, which looks for signs of stroke, and that is normal. So there is no stroke on the brain. The second sequence is a T2 sequence. And when we look at, or the second and third, excuse me, and we're looking in the right cerebellum. So kind of in the area, you see a little white area. Yep, that is an evidence of an old stroke. And then on the far right sequence, there is also another white area next to the ventricles, which represents a small stroke in the right thalamus. These are not acute because we do not see them on the DWI. So they represent something that occurred probably months before this injury. It's hard to know. That's one of the limitations of the MRI, in that we don't know when exactly it started. It doesn't give us exact time, but we can safely say that this started weeks to months before the presentation. The other part of the TIA that I think will be important to keep in mind for future is when we talk about TIAs, what we do with our students and residents is we always think about localization. And so when somebody comes in with slurred speech and a right facial droop, we worry about something on the left side of the brain, probably subcortical. So it could be in the left internal capsule, the left side of the upper brainstem, or in the right pontine area. Again, when we look at those areas, we don't see anything abnormal in the brain, which helps to diagnose the TIA, but it's something to keep in mind as we progress with the case. What we're seeing now on the blood vessels is normalcy. When we worry people with multiple strokes, multiple TIAs, we look for signs of clots in the blood vessels. In a case like this, we also worry about inflammation of the blood vessels, something called vasculitis, and we're just not seeing anything. So these are essentially normal tests. The other thing I look for in a young person who comes in with stroke is look for signs of tears in the blood vessels, something called a dissection, and we don't see that. So these are normal looking blood vessels.
Thank you very much for your complete explanations.
Yeah. Thank you, Dr. Balagage. Thank you for joining us and your report. I have a question about this patient. When you have a patient with these ages and this manifestation. What's your diagnostic and therapeutic approach for this patient? And the second question is that, can you differentiate embolic lesions from the in situ thrombotic lesion or not?
Yeah, great questions. So the initial, for anyone who comes in with a stroke and or a TIA, is what you have seen is that we usually want to take some pictures of the blood vessels. Usually we'll start with a CT scan in their emergency department to see if the patient has any bleeding or obvious signs of a stroke that would preclude them from any kind of acute treatment such as TPA or mechanical thrombectomy. And then the standard evaluations include looking at the heart, looking at the blood vessels of the brain. And then, although it's not considered standard of care in the United States, we usually like to get a brain MRI because we can pick up those small strokes, as you saw on the imaging, that helps us kind of determine etiology. And then we like to check for the most common cause for strokes is atherosclerosis. So risk factors for atherosclerosis, including diabetes, hyperlipidemia, so we would check some additional blood work in those situations. In a young person such as this, so a young female, I would consider hypercoagulable, especially since we see signs of stroke. So I would probably do additional hypercoagulable workup as well, including lupus, antiphospholipid antibody panels, genetic predisposition markers for hypercoagulability, and then monitor while the patient's in the hospital with a telemetry device to look for any kind of abnormal heart rhythms such as atrial fibrillation. And then your second question about can you differentiate between in situ thrombosis versus embolic? It is difficult to do in just on imaging or just from a clinical perspective. The gold standard is obviously pathological biopsy where we take the clot, look under a microscope, but even then it can be challenging to tell. There are some studies that are looking at trying to determine, including one that we do at our place for people who have large vessel strokes, to determine if people have embolic strokes, and they look at pathology and the amount of calcium in the clot, but again, nothing is definitive. With that being said, though, I will say that there are certain risk clues here that point in one direction or the other. The first is thinking about the localization of these. So what we saw on the scan is that the patient has a right cerebellar stroke, a right thalamic stroke, and then based on the TIA localization, we're looking at either left subcortical MCA territory, so left internal capsule, or somewhere in the brainstem. And so then you think about the vascular blood supply to those areas. The right cerebellum is supplied by the vertebral artery in the pike territory. The thalamic area is supported by the right posterior cerebral artery of the PCA, and then anything on the left side is the left MCA or left basilar or left vertebral artery. So right there we have three different vascular blood vessels. So the question is there some abnormality in the blood vessels that's causing the clot to form there directly? Well, we had that answer because we have the blood vessels. We don't see any abnormalities there. This could still be a small vessel that we're not picking up, but did clots form in these three small blood vessels directly? Or is it more likely that if you look at the common denominator for these, you take all those blood vessels because they're multiple blood vessel territories and find the common cause, the common uniter is the heart. So that raises the possibility of a cardioembolic etiology in this case because of this multiple blood vessel territory possibility. The second clue that I use to kind of determine if something is in situ thrombosis is that we look at the clots that we see. The clot in the thalamus and the blood vessels certainly could be what we call small vessel disease, or also known as lacunar strokes because they are so small. Lacunar strokes are typically caused by risk factors such as high blood pressure, uncontrolled diabetes, smoking, and occasionally hyperlipidemia. So these are these small atherosclerosis risk factors that blood clots form in the blood vessels over a small period of time. and because the vessels are so small, it doesn't take a lot of clot to form in them. So that still could be a possibility, but again, when we look at the imaging, typically we'll see clues. People with uncontrolled hypertension, hyperlipidemia, tend to develop what's called periventricular white matter disease. So we will see some stains on the brain in these areas, which we're not seeing on this brain. So that kind of points away from the small blood vessel risk factors. I also will use ancillary testing to help us. This is where an echo will help if we look, or an EKG, to see signs of LVH, left ventricular hypertrophy, to suggest ongoing hypertension. And then just using our history, does this patient smoke? Is this patient overweight? Does this patient have an elevated blood pressure prior to coming into the hospital? So those clues, and we don't see any evidence of that. So that points away from a small vessel lacunar type mechanism in this case. So pointing away from the in situ thrombosis in the blood vessels, and given the multiple vascular territories, I favor an embolic etiology.
Thank you. Thank you for your nice response and your great information. Thank you, Dr. Belagic.
So let's continue with the echocardiography of the patient.
I wait for the film.
Yeah, I will load it as soon as it be possible for me. Here, we're gonna play that. Dr. Sadaqian, is it necessary to replay that again?
Okay. Can you show the next slide, please?
Of course. Could you please have a report of the echocardiography and then explaining about that?
Yeah. Because I saw the echocardiography, but you can't see now. For this patient, we have esophageal and transthoracic echocardiography, and in transthoracic echocardiography, we can see some thickening of the anterior mitral leaflet and posterior mitral leaflet. And on transesophageal echocardiography, there are some verrucous vegetations on atrial side of AMVL and PMVL on coaptation point, and mild to moderate mitral regurgitation. About Lippmann-Sachs endocarditis, Lippmann-Sachs endocarditis involves entire surface and thickness of the leaflets, atrial and ventricular side. The beginning of the,
Sorry for inconvenience. Could you please have a report of the echocardiography at the beginning?
Would you please show the slide? Next slide, please. Yeah. Lippmann-Sachs endocarditis begins at coaptation points, but after it extends into the entire surface of scallops and both in atrial and ventricular side of the leaflets, there are verrucous or granular in appearance and have a broad base, and it is their difference with normal with endocarditis infective vegetations. Infective vegetations are narrow-based, but Liebman-Sachs endocarditis are broad-based and have firm attachment to the leaflets. Would you please show the report of echocardiography, the slide of the report? Would you please show the next slide?
Dr. Sadeghian, do you
Yeah,
have my voice?
Yeah. As you see here, in trans echocardiography, thickened mitral valve leaflets, mild to moderate mitral regurgitation, estimated pulmonary artery pressure about 48 millimeter, and in TE, multiple echo densities on the atrial side of the mitral leaflets at the coaptation point.
So we have the vegetations here.
Yeah, we have vegetations.
Could you run, Dr. Vijan, could you run the echocardiography as well?
Of course. I play it again.
You're not seeing it.
Yes. This is transthoracic echocardiography, and here you see thickening of leaflets. Yes, and please, yeah, and this is transesophageal echocardiography and varicose mass on coaptation point. And this is mild to moderate mitral regurgitation.
The third video is transesophageal echocardiography, if I'm not wrong, right?
Yes, this is transesophageal echocardiography.
I
Third
can
and
play it
second
again.
video, yeah. Only video one is transthoracic echocardiography. And video two is transesophageal, and varicose vegetation is here. And this is mild to moderate mitral regurgitation.
Thank you
Any
so
questions?
much. Of course,
Welcome.
Dr. Faizi.
Thank you, Dr. Sadeghi, for your report. I have a question about about the diagnosis of the patient with this vegetation on her heart valve. Can you explain about the diagnosis or differential diagnosis, and can you differentiate acute lesion from the chronic lesion by echocardiography or not?
Yeah, very good questions. First of all, about infective endocarditis and how to differentiate infective endocarditis from non-bacterial thrombotic endocarditis. Really, it is very difficult for echocardiograph to differentiate between them. But for Liebman-Sachs and non-bacterial thrombotic endocarditis, the vegetations are multiple, are varicose, and are broad-based. But in infective endocarditis, the vegetations are single, are very mobile and narrow-based. But always we do need two blood cultures, and without blood cultures and without lab tests, we can't make the definite diagnosis. So blood culture is obligatory. Another question about acute or chronic. Acute vegetations are more mobile, and chronic vegetations and healed vegetations are less mobile. And chronic lesions lead to valve thickening, and in acute lesions, we have mobile varicose like this lesion.
You mean that this lesion is acute in this echocardiography?
We have multiple vegetations on this echocardiogram. Some of them may be acute and some of them chronic. many times on echocardiography, we have both chronic and acute vegetations.
Yeah, that means mixed lesion. Yeah,
Yeah, mixed
acute
lesion.
and
Yes,
chronic lesion. Yeah.
yes, yes,
Thank
mixed
you.
lesion.
Thank you very much. Thank you for your response.
Welcome.
So let's continue with the case. As Dr. Sadeghian mentioned, for blood cultures, they were obtained for the patient and all were negative, and subsequently heparin was administered intravenously, and on the fourth hospital day, the rate of heparin infusion was decreased at 6-hour intervals when the PTD exceeded 150 seconds until the infusion was stopped. Here you can see the further workup for the patient in lab data at presentation and fourth day of hospital admission. As you can see, the PTT of the patient was increased at presentation, and again after heparin administration, it exceeded more than 150 seconds. Also, further workup was performed for the patient. A CT scan of the abdomen and pelvis revealed an enlarged heterogeneous uterus with multiple fibroids, as you can see here. And also a chest CT scan was performed revealing clustered nodules in the lower lobes that were probably related to aspiration. Unfortunately, we do not have access to the images of the chest CT scan. The patient then was referred to the third hospital, which was a tertiary center, and a NIU history was obtained from the patient. In the review system, no recurrence of dysarthria or facial droop was recorded. No other neurological symptoms. The patient reported heavy menstrual bleeding and exertional dyspnea in recent weeks, and also a pruritic macular rash on the trunk, scalp, arms, and the legs with associated photosensitivity that had persisted for many weeks. She also revealed new Raynaud's phenomenon in the past 10 months and a long history of dry eyes and seasonal allergies. In her past medical history, she confessed having undergone in vitro fertilization due to infertility. She had a first trimester spontaneous abortion at 25 years of age. And during her second pregnancy at 33 years of age, a screening RPR test was obtained for the patient, which was positive with a titer of 1 to 8 with a concomitant negative terpenomal specific confirmatory test. Pregnancy-induced hypertension developed in her second pregnancy, followed by placental abruption at 30 weeks, which has resulted in cesarean delivery. She also revealed sickle cell trait, vitamin B12 deficiency, iron deficiency, resulting in past iron infusions, and also there were uterine fibroids, anxiety, and hypertension in her past medical history. Let me just check with others. Is my was clear for everyone?
Yes, it is.
Thank you. In her family history, her mother had rheumatoid arthritis, hypertension, and a history of spontaneous abortion. And one of her grandmothers had diabetes and the other one had had a stroke. An aunt had had leukemia and later breast cancer, and her child has psoriasis. Her drug history included amlodipine, cyanocobalamin, ferrous sulfate, and medroxyprogesterone acetate depot. She had no known medication allergies as well. She lived in Eastern Massachusetts with her husband and child. She did not drink alcohol nor smoking tobacco. Surgical history included multiple laparoscopies and 2 laparotomies, including salpingioophorectomy for endometriosis. In her physical examination, the temperature was normal with heart rate as well, and increased blood pressure level of 155/98 millimeters mercury. Oxygen saturation was normal. She also had an increased BMI, body mass index, and also several small circular macules on her back, as you can see in the picture. And also there was a grade 2 out of 6 holosystolic murmur at the left sternal border and apex. No lymphadenopathy, petechiae, nail changes, or evidence of arthritis was revealed in the physical examination. Neurological examination was normal, and the remainder of examination was normal as well. So let's have a problem list of the patient, a 41-year-old woman with history of TIA, mitral valve vegetations, history of spontaneous abortion, false positive RPR test, pregnancy-induced hypertension, a family history of autoimmune diseases, and in physical examination, maculopapular rash was revealed, and also an increased PTT in her lab data. Dr. Faizi, we can have you now. Your microphone is DC.
Thank you, Dr. Bijani. I have a question from Dr. Khosrowshahi. Dr. Khosrowshahi, thanks a lot. According to this problem list, what's your differential diagnosis and what's your diagnostic approach for this patient?
Yeah, this is a great case. Definitely, if you see someone, a young person, a young woman with a significant history of autoimmune disease in their family, with major problems during pregnancy. The first thing was infertility. We don't know the infertility was due to miscarriages that she wasn't really identifying, or was it really due to procedures that she has had for endometriosis. False positive RPR test, and definitely preeclampsia that she experienced with her pregnancy, and now comes with hypercoagulable state, sounds like, with increased PTT. The differential is definitely antiphospholipid antibody syndrome. Is it associated with lupus or not? Is a great question. The physical exam shows a rash that looks like more subacute. I mean, we don't have a picture of her discoid rash that is described in the text later on her ears, but this could be, these are scars, majority of them, from a subacute cutaneous lupus. That could definitely make the criteria for SLE if we have the serology and more history. And sometimes, a lot of the times, patients come with one manifestation of lupus, and then you check the serology for them and they are positive, and then over a few months or so, they develop the rest. So I have a high suspicion that this young woman with this significant history during her pregnancy time could have systemic lupus and antiphospholipid antibody syndrome.
Thank you. Thank you.
Thank you very much. Here, as Dr. Khosrowshahi mentioned about a serology lab data, we have the serology lab data of the patient that you can see lupus anticoagulant levels are increased, and also anticardiolipin level was increased to about 10-fold, and anti-beta 2 glycoprotein level is increased for about 8-fold. And also we can see the antinuclear antibody titer, which is increased to 1:320, and also it has a diffuse pattern, and also we have a positive anti-Rho antibody. At the same day, a dermatology consult was obtained for the patient, which was mentioning about photodistributed erythematous and hyperpigmented macules were present on chest, back, and upper arms, and were suggestive of subacute cutaneous lupus erythematosus. A scarring alopecia was observed also in the occipital, nuchal, left vertex, and right parietal regions of the scalp, with associated hyperkeratosis and areas of hyperpigmentation and hypopigmentation, which was diagnosed as discoid lupus. Dr. Faizi, we can have an opportunity if you have any question from Dr. Khosrowshahi.
Dr. Khosrowshahi, according to this result of the autoantibodies, and now what's your diagnosis and what's your therapeutic approach for this patient?
Yeah, putting all the things together in terms of history, physical exam, and lab that we have at this point, we can make a diagnosis of systemic lupus erythematosus. If you take any of the classification criteria that are majority of them for classifying lupus patients for clinical studies, not diagnostic, but even those are met. She has a discoid rash. She has subacute cutaneous rash, which gives another point. She does have a positive ANA, and then antiphospholipid antibody positivity. She makes 4 of those, regardless of her history of TIA, which is a hypercoagulable state, regardless of the Lippmann-Sachs lesions that we saw. So I am pretty confident when I see someone like this that they have systemic lupus erythematosus. So what's the next approach? Yes, we have to consider there is an acuity. The reason this patient came to the hospital was the TIA. And now we have a vegetation that is sitting on the leaflet of the heart. So there is another possibility, and it's pretty high, that she may have another embolic event, and this time may not be a TIA. So the first thing is treat or prevent that event. Meta-analysis studies have shown that patients who have high titer auto antibodies for antiphospholipid antibody, they have 6-fold increased risk of thrombosis if they haven't had any thrombotic event in the past. That's for just someone that will incidentally check these. But for someone who has had activity, including preeclampsia, maybe miscarriages, and now comes with TIA and has Lippmann-Sachs, definitely she needs to be anticoagulated. So that's my approach. But regarding her lupus diagnosis, when we have a lupus who has photosensitive rash and discoid rash, one of the first things that we start and we know changes the outcome of these patients long-term is hydroxychloroquine. So hydroxychloroquine not only is going to be effective for her lupus, has some anti-thrombotic effects and would be helpful in long term for preventing, I wouldn't say preventing really clotting, because clotting can happen on hydroxychloroquine, and that's for sure it's not an anti-thrombotic, but it would definitely help with modulation of these antibody production that is the cause of her hypercoagulable state.
Okay, thanks, Dr. Khosrowshahi. About the type of the anticoagulation, what do you suggest? Do you suggest any kind of anticoagulant for her, or no? We can use any anticoagulation?
We usually consult neurology just to make sure it's okay, because with acute stroke and TIA, we try to make sure that we don't do anything that would cause more harm, and I will let Dr. Blagaj discuss that. But if it wasn't a stroke and it was some other thrombotic event, we would definitely go with the heparin to start with. With the stroke, we ask neurology to make sure that it's okay to do that.
Can you, after heparin, do you start warfarin, or can you use any DUAC for this patient or not? What's your suggestion?
These are great questions. So there is a lot of controversy in terms of like what is the best anticoagulation for patients with antiphospholipid antibody, and it's like antiphospholipid antibody positivity or it's antiphospholipid syndrome. So those are two different discussions. I don't want to go to too many details, but we have a patient in front of us who is having a thrombotic event and we want to manage this patient. Usually in these situations, we start with heparin and bridge them to warfarin. And we do not use DOAC because the studies have shown that actually we were lacking really good studies head-to-head to evaluate the efficacy of DOACs for antiphospholipid antibody patients. Now there are some retrospective results coming back, and it's not recommended. So for people who are at risk of thrombosis due to antiphospholipid antibody syndrome, we still try to stick to warfarin. That's in theory. In practice, we do have patients that do not like to continue warfarin because of the frequent blood checks and hard diets that they have to go on when they take warfarin, any vitamin K antagonist. So there are people that after many years that they don't have clots, they decide to go to a DOAC, although they know that it may not be the best option. But the recommendation, academic recommendation, is usually to keep them on warfarin and with an INR of 2 to 3, depending on what exactly their clotting issue has been. Which again brings us back to the issue of even how to monitor these patients. But I will stop here and I will see if we have any comment from Dr. Bulagaji.
Yeah, Dr. Bulagaji.
Yeah, no, that's a great discussion. Yeah, I would also agree, given the acute presentation of a TIA, and then we see these vegetations and kind of putting this is Lehmann-Sachs endocarditis, the treatment is anticoagulation. The question then becomes, is it safe to anticoagulate? Because as you saw with this patient, starting the heparin increased the PTT very quickly. So these patients don't have normal coagulation and clotting factors, so they can bleed very quickly. So it's important to keep that very good control, and there's a high risk of bleeding with these patients. So we would, in this case, fortunately, the patient does not had a TIA, so no acute injury, or also the strokes that we see are old, so suggesting that the risk of bleeding is very small, and these are also very small strokes as well. So I would be okay to proceed with anticoagulation, starting with a heparin drip and transitioning to a warfarin. And the one thing I will add about warfarin is that these patients can still have thrombotic and thromboembolic events, even in the setting of a therapeutic INR. It's often one of my questions that I ask our residents and fellows when we'll see similar patients who come in and they will say, oh, the patient's INR is therapeutic and it'll be between 2 and 3. And I'll say, well, what else could be going on? And then that's when we will maybe do additional testing and find that the patients have antiphospholipid antibody syndrome or a lupus anticoagulant positive, in which case then we would push the therapeutic range above like a 2.5 to 3.5. And if this patient did have a stroke, this becomes a little bit more complicated. I think in this case, I would still recommend anticoagulation because that the presence of the vegetation and a high risk of embolic events. I think that the risk of embolus outweighs the risk of bleeding. But to minimize the risk of bleeding, we would use a modified heparin drip using a lower PTT, and then avoid boluses to limit the risk of bleeding, and then ultimately transitioning to warfarin. I was glad to hear about the comment about the DOAC, because in preparation for this, I was just looking at the current literature. The way I was trained is that we would use warfarin, but I trained before DOACs were available. So I was just looking to see if there's any recent evidence, and the evidence still, guidelines still suggest using warfarin above the DOACs on these cases.
Thank you.
Thank you,
Can I
Dr.
add something?
Bulagaji. Yeah, please.
So in continuation of the discussion, thank you for bringing that up, about the PTT elevation and PTINR. assays that are not very accurate for patients with antiphospholipid antibody syndrome. We know the mechanism. So the cardiolipin exists in their blood and the serum mixing assays don't correct. And for that reason, it's very important that we have the baseline. So we know what's the baseline of these patients in terms of, like we saw, the PTT was elevated in this patient. And then majority of these people, if we have issues with following up the PTT, we usually check the factor VIII activity. That's more accurate for these patients, specifically if you are dealing with arterial thrombosis and multiple thrombosis that we need to keep their PTT elevated. If not, as it was mentioned, we try to avoid in cases of a stroke or cases that there is a risk of bleeding in these patients, like thrombocytopenia. A lot of our patients with lupus and antiphospholipid syndrome come with thrombocytopenia, low platelets that would increase their risk of bleeding. In those cases, we try to very closely monitor their factor X activity. But if it is a patient that doesn't have much risks and we need to discharge them quickly and we need to put them on warfarin, so it's not as easy to check factor II and factor VIII activity, factor X activity for, factor II and 10 for INR. We usually try to calculate their own INR based on their baseline. So what was their baseline before they were started on anticoagulation, and what is their after, and try to make sure that we adjust it. But even then, we deal with some patients who will develop arterial thrombosis being on the right therapeutic INR, and those are the patients that we have to keep them on low molecular heparin for the rest of their lives.
Yeah. Thank you, Dr. Khosrowshahi. This patient is a triple positive antiphospholipid syndrome and with high level of antibody. And you know that these antibodies are effective and cause some manifestation. What's your opinion about the use of steroid or immunosuppressive for this patient? And the other question is that if this patient has any manifestation of the lupus, such as macular rash or positive FANA, what was your suggestion for treatment of this patient with just APS?
That's a great question. In terms of use of corticosteroid for just elevated antibody levels, there is a still controversial evidence out there. As long as patients are not having catastrophic antiphospholipid antibody syndrome, which involves multi-organ involvement and kind of like end-stage organ involvement, we usually don't go to a steroid for just treatment of antiphospholipid antibody. We don't treat the level of antibodies. But I hear your concern. So there is an autoimmune process that is producing these antibodies, and we don't want to wait until they get there. Majority of the rheumatologists, the way they approach it, just add hydroxychloroquine with anticoagulation for treatment of the thrombotic event or antiphospholipid antibody syndrome. When they have Lippmann-Sachs lesions, you know that there has been deposition of these sterile platelets, platelet thrombi on the heart valves, and there has been some endothelial damage due to the hypercoagulable state and probably these autoantibodies that are circulating. So again, it's important to make sure that this endothelial injury and this platelet deposition doesn't happen. But on the other hand, there has been multiple studies looking at these treatments with a steroid can actually cause worsening of the fibrosis and scarring of the valve leaflets. So there is always this balance of when to use a steroid, when not to use it. The way that we approach these patients is we don't need acute treatment with a steroid if you don't see inflammation on your exam, on your blood work. You anticoagulate this patient, but start the management of modulation of their immune system with something that is mild immunosuppressive, but at the same time is going to have a long-term effect on the modulation of their immune system. I think in this case, hydroxychloroquine was used. But honestly, if she had more activity, she had arthritis on exam or active rash, I would go to a steroid use for that reason, not for the Lippmann-Sachs lesions.
Yeah, what about the other immunosuppressive? You don't
So-
prescribe any other immunosuppressive, such as azathioprine, with this level of the antibodies for this patient?
Not just because of the antibodies that are high, but because of, I think, this is a predictor of this patient is going to have other organ damage. And you are right. I mean, I would not probably start her in the hospital, but after further evaluation at some point, yes, you are right. We would do that. I have had patients who had multiple clotting and high antibodies, even without catastrophic antibody syndrome. If they have arterial thrombosis and really triple positive antibodies, we would go to even medications like rituximab, a B-cell depletion agent, to just make sure that the antiphospholipid antibodies don't cause major problems. We have used eculizumab, which is a C5 complement inhibitor for those patients. But those are usually for cases that have significant thrombotic events. For just pregnancy complications and one episode of TIA, I think anticoagulation is enough.
Thank you. Dr. Khosrowshahi, do you need any level of the antiphospholipid antibody in your follow-up? When patient come back and you need the level of the antibody and it can change your therapeutic approach or not?
That's a great question. A level of antibody usually does not change the management if you have made a decision that this is definitely antiphospholipid antibody syndrome. There are two scenarios that we check those. So first of all, as you know, Sapporo criteria or Sydney criteria for antiphospholipid antibody syndrome emphasizes that these antibodies need to be repeated more than 12 weeks after. The reason, I mean, sometimes it may sound like, why? I mean, this patient, for anything you name it, has all the antibody levels. They are very high and she has episodes. So this is definite. I completely agree that probably there are patients that with even one set of antibodies and clinical history, you can take away that diagnosis from them with repeat one. But I've been burnt before. Patients who come with acute illnesses, with acute infections, they are very sick in the hospital for other reasons. They can have falsely, or I wouldn't call it false, I would call it transient elevation of antiphospholipid antibodies. And they have been high, very high anti-cardiolipins and anti-beta-2 glycoprotein, but after they are better, 12 weeks later, you repeat, they are negative. I still have suspicious, okay, maybe this is wrong. The first one was right, but you repeat them and they never come back positive. So that transient elevation of antiphospholipid antibodies have been seen with acute illnesses. We saw it a lot with COVID patients. And after that, it completely resolved. For giving the diagnosis and committing these patients for long-term, lifelong anticoagulation, that's why you repeat it 12 weeks after. But to answer your question about the titer, titer usually does not change my approach. If the patient has positivity and has had clots, I would keep them on anticoagulation. The only times that I have done it is when they are asking me if they can switch to DOAC, if they can stop their anticoagulation. And I mean, in real life, that happens. These are young women and they don't want to continue the anticoagulation forever. They haven't had clot other than one episode that sometimes you feel like maybe was provoked, maybe there was a estrogen progesterone and contraceptive use at the time and they are not doing it anymore. In those cases, I may repeat the titer, and if the titer is as high as it was before or higher or even high enough, I would tell them don't stop. But if the titer is gone, or is much lower. So I have a little bit flexibility with monitoring them closely and letting them do that.
Yeah, thank you. Thank you very much for your nice information. Dr. Khosrowshahi, do you know that this patient has a history of the progesterone administration before the TIA? Do you think that the etiology of the TIA in this patient may be progesterone consumption or not? And if you notice that the patient has positive for antiphospholipid antibody before prescription of the progesterone, what do you suggest for this patient?
Yeah, these are really tough situations. So as you all know, use of estrogen progesterone combination, contraceptive medications or hormonal treatments are contraindicated in patients with significant lupus and antiphospholipid antibody positivity. Progestin only medications, especially the oral ones, are okay and low risk for these patients. So if they are going to take a medication for contraception, we tell them the progestin only has lower risk, but it still has a risk. So we usually recommend them to have an IUD and try not to use hormonal treatments. But if they are going to use hormonal treatments, progestin only is safer. In terms of depot injections, which has a third generation of the progestin hormones, actually the risk is higher than the progestin only combinations. And I believe that probably the 5 days and then 3 days course that this patient received probably tipped her over. Not that it caused it. She had the Liebman-Sachs lesions. Those thickening of the leaflets didn't happen just in the past few weeks of this patient history. So they were there, but definitely the amount of depot medroxyprogesterone that she received increased the chance of having an embolic event in her case.
Yeah, thank you. Thank you very much, Dr. Bijan. You can go.
Can I just jump in there real quick about the progesterone?
Of course.
Yeah.
Of course.
I completely agree. I think that the progesterone administration was indirectly involved, if at all. It was not the direct cause. And just as you heard, looking at the stroke data, there was, when these oral contraceptives came out, we were always concerned, is there a slightly risk? Because we know from animal data that there's maybe a slightly high risk of hypercoagulability. And then there were some initial studies, but looking at oral contraceptives, the risk is very low. So usually it's about a 1.4 risk, so kind of close to 1, really negligible. And then when we look at the progesterone only combinations, there's been no additional risk. So those are available. The other reason I don't think it's directly involved is because of the MRI findings. If you recall that there was evidence of strokes that were there that occurred weeks to months, that these are not acute stuff, but these occurred weeks to months before these symptoms, before the TIA occurred. And this was also occurred weeks before the progesterone was administered. So I think that if it was involved, it may have just tipped them a little bit, but it was not the direct involvement.
Thank you.
Thank you so much. Let's continue with the case. Also, a gynecologic consult was obtained for the patient, which pelvic ultrasound was performed for the patient, showing an enlarged uterus with multiple fibroids, and also given the patient's history of TIA, treatment with medroxyprogesterone acetate was initially discontinued, and instead a levonorgestrel releasing IUD was placed, which was discussed just a minute before. And finally, the patient was diagnosed as antiphospholipid syndrome plus systemic lupus erythematosus regarding the lab data and also the imaging and history of the patient. And then the patient was treated with emphasis on protection of the skin from UV light, and also hydroxychloroquine was administered for the patient, and also heparin administration was transited to warfarin. Dr. Faizi, we're here to you asking questions.
I asked most of the question from Dr. Khosrowshahi. I have a question from Dr. Bilagage. If this patient has just TIA with no Lehman suck, means a patient with APS, TIA and a triple positive antiphospholipid syndrome, what was your therapeutic approach for this patient?
Yeah, I don't think it changes. I still think it's anticoagulation because this patient has shown evidence of having a history of thrombotic events, and it's going to be a lifelong anticoagulation use. So I would continue with the anticoagulation. Where the Liebman-Sachs endocarditis comes in is that you still anticoagulate, knowing that there might be some damage to the valve. So you would want to get our cardiology colleagues involved to see if there might be any reason to do any kind of valvular repair. But otherwise, I would continue with the anticoagulation.
Yeah, thank you. I have a question from Dr. Sadeghi. When do you suggest valvular surgery for this patient or any patient with Liebman-Sachs endocarditis?
Yeah, thank you for your question. For Liebman-Sachs endocarditis, like other endocarditis, when we have severe mitral regurgitation or heart failure or repeat embolic event after start of treatment, we must refer the patient for surgery. But with this stage, we only treat the patient and follow the patient.
Let's have the follow-up of the patient. An examination was performed 6 weeks after discharge of the patient from the hospital, revealing new inflammatory arthritis of the elbows, knees, and ankles. The patient continued treatment with hydroxychloroquine with a notable abatement of the rashes and her symptoms of redness phenomenon. Also, a follow-up thoracic echocardiogram was performed and showing no increase in mitral vegetation, and mitral regurgitation was reduced to trace to mild. She also underwent uterine fibroid embolization 6 months after initial presentation, and also 8 months after presentation to this hospital. The patient is doing relatively well and continues to receive hydroxychloroquine. Repeat tests for APS antibodies have remained triple positive, and she also continues to receive anticoagulation therapy with a plan to continue indefinitely. We would be pleased to have your questions as Dr. Bahovand. You can type in chat box, and now we're gonna have Dr. Faizi's literature reviews, which would be brief. Dr. Faizi? Your microphone is DC again.
I'm going to give some literature review, and I tried, it's not work. Doesn't work. Yeah. I start the literature review with this question, that whether the current treatment for APS can decrease the disease burden and morbidity of the patient or not. I try to open just this question and may no answer to this question completely. You know, the APS is an autoimmune disease that characterized by presence of the antiphospholipid antibody that cause thrombophilia and some obstetric event and miscarriage and some vascular events such as accelerated atherosclerosis, increased risk of myocardial infarction, stroke, valvular heart disease. And we know that morbidity and mortality in antiphospholipid syndrome is related to vascular cell dysfunction. So in this figure, you can see that antiphospholipid antibody has different effect on blood vessels. The main and the well-known mechanisms is formation of the clots and thrombosis that act through the different mechanisms such as activation of platelet, dysfunction of endothelial cells, complement system activation, and neutrophil activation. This is one of the well-known mechanisms of antiphospholipid antibody. But these antibodies has different effect on blood vessel. They can activate a receptor that named mTOR in endothelial cells, and they can induce endothelial proliferation and intimal hyperplasia. You can see here that these antibodies by this mechanism can make a vascular narrowing, and this vascular narrowing can induce some CNS manifestation and pulmonary hypertension without thrombosis, and in renal can induce hypertension. Sometimes both pathogenesis occur simultaneously. That means patient has vascular narrowing and thrombosis as well. And the other mechanism is accelerated atherosclerosis. So in this pathogenesis, we noticed that all of these manifestations occur due to presence of the antiphospholipid antibodies in circulation. And the same as these mechanisms, the mechanism of valvular injury is the same as this, and it is due to a valvular endothelial cell dysfunction. You can see something like this on valvular cell, that the same as vegetation. So in this meta-analysis shows that antiphospholipid is associated with not only a clinical adverse cardiovascular event, but also with subclinical cardiovascular events such as increasing intima-media thickening. In this study, Cervera and et al. In a large prospective cohort study of 1,000 patients with APS over 10 years shows that the incidence of the Liebman cells is around 5% over 10 years. These studies shows that antiphospholipid levels can increase mortality due to coronary artery disease and myocardial perfusion defect as well. These 3 studies shows that the level of the antiphospholipid antibody may be important in some morbidity of the patient. And this study, this meta-analysis shows that antiphospholipid antibody increased the risk of limb mass 3-fold. And this meta-analysis shows that in patients with SLE, valvular heart disease, including valvular thickening and vegetation, are among the most common valvular involvement. And the presence of diffuse valvular thickenings in 2 leaflets or 1 leaflet with vegetation can use as an imaging diagnostic criteria for Lehmann-Sachs endocarditis. Roldan shows that the patient with vegetation has 3 times more cerebral microemboli events, such as and more stroke and TIA as well. Cervera shows that around 90% of the APS patients were still alive at 10 years. That means a good survival for APS patients. But Despite high survival rate, these data reflect the substantial disease burden and morbidity in patients with current treatment that we use for APS. And Corban said that it's unclear whether antithrombotic therapy limits the development of valvular injury in this setting or not. I found this was a very interesting study that Roldan was done. Roldan study on SLE patient with Liebman-Sack and acute cerebrovascular events such as stroke, TIA, focal brain injury on MRI, and cognitive dysfunction, and evaluate the conventional anti-inflammatory and antithrombotic therapy for patient, and repeat cardiac and central nervous system evaluation in 6 months. They found that valve vegetation decreased in number, diameter, and area associated with decreased the valvular regurgitation, and that significantly improved, and valve thickness didn't progress. Also, cerebral microembolism, lobar and global gray and white matter, cerebral perfusion, and neurocognitive dysfunction resolved significantly and improved them. That means some drugs that we use for treatment of the patient with SLE, such as steroids, such as immunosuppressive, can reduce the valvular involvement, and especially some cerebrovascular involvement. If we accept this pathogenesis, I think, in my opinion, that we should change our concept about the treatment of the patient with antiphospholipid syndrome. And now we just use anticoagulant as the main treatment for this patient because thrombosis is well known, and we don't consider the other effect of antiphospholipid antibody. And just we use platelet drugs in addition to anticoagulant. But as Dr. Khosrowshahi mentioned, it's better to use drugs that decrease the level of the antibodies, because these antibodies are the main source of the manifestations. It's individualized. It's depend of the patient. It's better to use some immunomodulator or sometimes immunosuppressive anti-B cell drugs, and even IVIG and anti-complement. And the other treatment is sirolimus, that is anti-mTOR drugs. This drug is used for patients with APS that did renal transplantation, and they show that some study shows that this drug can prevent allograft renal vasculopathy. That is very important. That show the effect of a drug on this pathogenesis of the antiphospholipid. In this slide, I'm going to review this patient, and I need help of Dr. Khosrowshahi as well. You can see the patient at 25 years of age has a first abortion in first trimester. And when she was 8 years later, when she was 33 years old, she has a pregnancy-induced hypertension and a false positive RPR without any more evaluation for antiphospholipid antibody. You know, the RPR test has the antigen of RPR contain cardiolipin. And 8 years later, she presents with vaginal bleeding, and medroxyprogesterone acetate was used for her. And 16 days later, she has a diagnosis of antiphospholipid syndrome, and SLE, and antiphospholipid syndrome with Liebman-Sach and TIA. You know that false positive RPR can be due to presence of the autoantibody, antiphospholipid antibodies. And unfortunately, there is no recommendation to evaluate antiphospholipid antibodies in pregnant people with false positive RPR. Dr. Khosrowshahi, can you help me for this discussion in this slide and get your opinion?
Yes, as you mentioned, so false positive RPR is actually very common because of the antigen is the cardiolipin. So for different reasons, this test can be false positive, and that's why actually when you have a positive RPR, you have to repeat a troponemal test to confirm it. There is a need for confirmatory test. It's not just antiphospholipid. Pregnancy itself can cause false positive. And because of that, our OBGYN doctors don't take it that seriously, that if it is false positive, so they just make sure that it's not syphilis, and they don't go ahead and do an antiphospholipid antibody positivity. If this patient for any reason would have come across a rheumatologist or I think a hematologist would have checked antiphospholipid panel for them at that time. But since she had no other symptoms to go to rheumatology, so I guess this was missed. But I completely agree with you. Not only false positive RPR, but multiple abortions, preeclampsia, they are all red flags that this patient had something going on, and it should have been checked at that time. And I would definitely, if someone has a false positive RPR, check antiphospholipid panel. If a patient has history of miscarriage and then preeclampsia in one pregnancy, regardless of the false positive RPR, I would still check antiphospholipid. Any of our lupus patients who is trying to get pregnant, we definitely make sure that they have antiphospholipid panels checked, they have raw antibody checked, as you know better than me. But those are things that needs to be done for workup.
Thanks you, Dr. Khosrowshahi. Do you find any recommendation for checking of the antiphospholipid antibody for patient with RPR false positive in US or not? Is there any recommendation or no?
It's not recommended, and the reason is because the rate of false positive RPR is very high. So if you want to check antiphospholipid antibody for anyone who has a false positive RPR, it would be very costly and probably not cost efficient to do it for everyone. So it's clinically indicated if there is another reason for that.
Yeah, thank you very much. And so as the Dr. Khosrowshahi mentioned, may early diagnosis could prevent morbidity and some may prevent TIA or may prevent Liebman-Sach in this patient. And in my opinion, in autoimmune disease, early diagnosis means prevention. And in that patient is if we have a diagnosis at this time, at the second pregnancy, may have a different course of the disease and may prevent some morbidity for this patient. And now, thank you, everyone. And if anyone has a question, we are going to answer them by our invited speaker. There is a question about the Liebman-Sach that ask anticoagulant only used for them or not. Dr. Khosrowshahi, do you have any comment?
Yes, so that's a very debatable question. So you showed the literature that there was a study that showed actually these patients after immunosuppressive medications decreased the thickening of the leaflet of the valves, and some of the vegetations got smaller. Prior to that, actually older studies from 1990s showed that steroid treatment worsens the leaflet thickening. So I would be very happy to see what Dr. Sadeqian thinks about that. So these are debatable. So it's individual based. That's why there is no guideline. So if you look at the literature, you don't find that their Liebman-Sachs lesions need to be treated with an immunosuppression or steroids. It's individual patients. You have to look at the whole patient together and make a decision. If the Liebman-Sachs lesion is just a scarred and fibrosis from all the scarring, I don't think there is any point of immunosuppressing that patient if there is no other activity. But if there is acute presentation with the inflammatory process going on, and it looks more acute in the setting of like more vegetation coming on, probably there is. Definitely you have to do the first thing to make sure that these don't cause embolize, and after that make a decision what's needed. As Dr. Sadeghian mentioned, there will be patients whose leaflets are completely dysfunctional and they may need surgery, and in those cases you don't want immunosuppression or steroid treatment, which would interfere with the function of the valve.
Thank you very much. Dr. Sadeghi, please.
Yeah, thank you for very good debate. One of the most large studies in the literature is done by Roldan et al. First study is published in 2012. And it is very interesting study because they enter in the study the patients with SLE and APS, but they enter in the study 29 patients with neurologic symptoms and about 40 patients without neurologic symptoms. And the most important thing that they found was that in the patients without neurologic symptoms, they have Liebman-Sachs. And this is the very important. So we can have Liebman-Sachs vegetations without neurologic symptoms. And they found that even without neurologic symptoms, in the first study, when they follow the patient developed neurologic symptoms. So they recommend that we must treat Liebman-Sachs before starting neurologic signs. And they recommend hydroxychloroquine, prednisolone, and also treatment with heparin and warfarin. And for Liebman-Sachs, when we have APS, only APS, we cannot treat the patient with heparin and warfarin. We must have APS with a thrombotic event that we start heparin and warfarin. And INR, the optimal range of INR is above 2.5 and between 2.5 and 3.5. But if we have Liebman-Sachs without neurologic problems, we can start heparin and warfarin. Is it clear?
Yeah, thank you. Thank you very much. Dr. Bilagage, do you have any comment?
No, I agree with what's been said so far that it's anticoagulation. The current recommendations here is that we start with anticoagulation, and then we would refer patients for possible valve surgery if there was some sort of compromise in the hemodynamics of the heart, or if they continue to have continued strokes or embolic events despite being therapeutic on their anticoagulation. But it's a case-by-case basis, but we generally start with anticoagulation alone.
Just
Yeah,
a
thank you
comment
very
about,
much.
about the
yes, please.
hydroxychloroquine. So if you look at the studies long-term, even now the recommendation is patients who have only antiphospholipid antibody syndrome, not even SLE, to get started on hydroxychloroquine because of the long-term effect that it has in terms of the reducing the inflammation, reducing the cytokines that are causing the endothelial injury for these patients. And that is, I don't think we can debate with the outcomes of hydroxychloroquine treatment for patients who have Liebman-Sachs or just antiphospholipid antibodies. That's completely established with the literature. But choosing other immunosuppressive medications just for the antibody elevation or Liebman-Sachs is debatable, because I completely agree that there is a role for immunosuppression and trying to modulate their immune system so these attacks are not happening to their vascular. The only problem is we do not have immunosuppressive medications that their side effects, long-term side effects, weigh in with the benefits that they may have for these patients. So I wish we had something like hydroxychloroquine, or now you're talking about belimumab, which is a expensive hydroxychloroquine, and most likely belimumab long-term would have that effect. But using medications like rituximab or eculizumab or even steroid long-term, these are young patients we're talking about. Long-term, they're gonna have worst outcomes if you follow them longitudinally. We use rituximab for patients with antiphospholipid antibody syndrome if they are coming with thrombocytopenia, and there are a pretty good number of those patients that have a combination of thrombocytopenia and antiphospholipid syndrome. That's the best medication to use because it helps them to actually have their platelets back and reduces their antiphospholipid. But in a patient that has no other manifestation and they come and they just had antiphospholipid antibody elevation, I still think that we should follow them very closely, definitely start them on Plaquenil, definitely start them on antithrombotic effect, and make a decision quickly to start immunosuppression if there is an evidence of increased inflammation.
Yeah, thank you very much. You know that antiphospholipid syndrome is a range from asymptomatic patient to catastrophic APS. And as you mentioned, we should treat patient individually. If the patient is near to the catastrophic with the multiple manifestation of related to antiphospholipid, it's better to decrease the level of the antibody by immunosuppressive or by B-cell reduction. And, you know, it's dependent on the patient, really.
Thank you so much, everyone, for the great discussion you had. I really enjoyed that. Dr. Fauzi, is there any comment that you want to add?
What?
Is there any comment that you want to add?
No, this is the first CPC that we start to talk about and discuss about the especially lupus patients. And we are very glad to have two invited speakers from USA. And we hope to see you in the next cases as well to discuss about this really difficult and multi-system organ involvement that very challenging. You know, sometimes there is no any evidence in the literature, but we have to make a decision for a patient because we have to help patient and prevent morbidity and even mortality for the patient. I hope to see you in the next session as well. Thank you, everybody, for joining us. Thank you, Dr. Sadeghi, Dr. Bijani, Dr. Baharwan, and everybody that joined us. Dr. Sadeghi, do you have any comment?
Thank you for all of these good events. And I have a question from dear Dr. Samir. Do you start aspirin and Plavix for this patient or no, with respect to TIA?
Do I start what? I'm sorry, I didn't hear the question. Can you repeat the question, please?
Do you start aspirin and Plavix for this patient because of TIA?
Oh,
aspirin
great
and Plavix
question.
plus warfarin, yeah.
Yeah. Typically, yes, we would start initially just to give them initial coverage, because if you're thinking in real time, you know, we're checking the lab work. And if you look at even the time course on this hospitalization, it took several days before that the echo and the ultimate diagnosis was made. So during that time, we would put patient on aspirin. But once the vegetations came on and we started the heparin drip, I would stop the aspirin and Plavix to minimize the risk of bleeding, and you're not getting any additional benefits.
Thank you.
Yeah, thank you.
Thank you
very
so much, everyone. Thank you. We were really super honored to host you, and we hope to visit you in our next sessions. Let me thank leading House of Iran and North America Academic Partnership and a Praise to Raise team for their generous help and support, and also thanks to our audiences. Dr. Bahovan, do you have any comment?
Thank you very much, everybody. I just wanted to add that we will be very grateful if you could fill in the feedback forms. I have shared the link of the Google form in the chat forum, and we would be really grateful if you could fill in those forms for us. Thank you.
Thank you so much, everyone. Have a nice day.
Thank you.
Thank you. Thank you. Bye.
دکتر خسرو شاهی خیلی متشکرم که به ما جوین شدید.
ممنون از شما، خیلی هم عالی بود. من واقعا خوش